You are so warmly welcome to this Metal education session. If this is your first time joining us, you're very warmly welcome indeed. And a little bit about Metal, we are a passionate community of healthcare professionals who believe in making great medical education accessible for every healthcare professional everywhere. I hope you find today's session really useful for your practice. Before we begin, it's really important that we share our disclosures with you, and I'm just going to bring those up on screen now for your information. In today's session, we have got some incredible education, and we're going to cover three main topics. First, we're going to learn how to apply clinical evidence, guidelines, and patient-specific factors to select and personalize first-line BRAF-targeted therapy for patients with BRAF V600E mutant metastatic colorectal and non-small cell lung cancer. We're going to learn how to implement proactive strategies to monitor and manage adverse events associated with BRAF-targeted regimens to maintain treatment continuity and optimize patient outcomes. And we're going to learn how to demonstrate the ability to identify, order, and interpret appropriate biomarker tests to inform first-line treatment decisions in metastatic colorectal and non-small cell lung cancer. But before we dive into our education, what we'd like to do here at Metal is to just assess where you're currently at in your learning journey. So what I'm going to do is bring up some polls, and it's really important for us to frame our education around some patients. So what I'd like to do is to hear your thoughts on how you would manage these patients, and then we'll dive into our education. The first case is this. A 68-year-old male with newly diagnosed unresectable metastatic colorectal cancer presents with a tumor in the ascending colon on the right side and is confirmed to have a BRAF V600E mutation, RAS wild type, and microsatellite stable. His ECOG performance status is 1. Based on the findings in the Breakwater trial, what is the most appropriate first-line regimen now considered the standard of care for this patient population? If you could share your thoughts in the poll, that would be super. If you just let us know how you would manage that patient. Okay, super. Thanks, everyone. If you're just joining us, we're doing some polls. You'll find them in the chat box on the right-hand side of your screen. If you're joining on mobile, just click the little chat icon, and that'll take you into the polls. If you could share your thoughts in those polls, that would be great. I'll give you a second just to do that. Super. Thanks, everyone. Great. Okay, I'm going to bring up our second poll, which is this. A patient with BRAF V600E mutant metastatic non-small cell lung cancer is starting first-line treatment with encorafenib plus binimetinib, knowing that treatment-related adverse events occurred in 94% of patients in the Pharos trial. The care team should be most prepared to manage which two of the following all-causality adverse events, as they were most frequently reported across all grades in the overall population of that study: A, B, C, D, or E. If you could share your thoughts, that would be super. Thanks, everybody. If you're just joining us, we're doing some polls. You'll find them in the chat box on the right-hand side of the screen. If you've missed the first one, you can scroll up and you can pop an answer into it as well. It's still available to place an answer on. And then we'll dive into our next case, which is this. Okay, so for this case, I'd love to hear your thoughts. For a patient with newly diagnosed metastatic colorectal cancer, the urgency of BRAF V600E mutation testing is high due to prognostic and therapeutic implications. If tissue is unavailable, which alternative detection method is supported, with studies showing a reasonably high concordance with tissue analysis for BRAF status in metastatic colorectal cancer? And if you don't know the answer, don't worry. We're going to cover all of this in our session today, but I'd love to hear your thoughts before we begin. And really appreciate you sharing your thoughts on those polls. Thanks, everybody. I'll give you a few seconds just to read. Okay. And the next poll is this. The Beacon CRC trial was pivotal for establishing BRAF targeted therapy in metastatic colorectal cancer. This trial focused on patients who had progressed on prior systemic therapy, second-line setting. What combination was FDA approved for this setting based on the Beacon trial, demonstrating a significant improvement in median overall survival compared to the control arm? A, B, C, D, or E? If you could share your thoughts in that poll, that would be super. Okay, great. Thanks, everybody. Super. I'll give you a second just to answer. And if you're just joining us, we're doing some polls, and we'd love to hear your thoughts on management in some of these scenarios. You can answer each of the polls in the chat box on the right-hand side of your screen. You just scroll up and you can answer each one if you've missed one. And if you're joining on mobile, just click the little chat icon at the bottom. It'll bring up all of the polls. Okay, the next one is this. What range most accurately reflects the incidence of BRAF V600E mutations in metastatic colorectal cancer? If you can share your thoughts, that'd be great. A, B, C, D, or E? And I'll give you a few seconds to respond. Okay, super. Thanks, everybody. Okay, and the final quiz question is this. I'm just going to bring it up on your screen. Which of the following describes a key finding regarding tolerability and quality of life in the Beacon colorectal cancer trial comparing encorafenib plus cetuximab to chemotherapy control, specifically related to the duration of quality of life maintenance? A, B, C, D, or E? If you share your thoughts, that would be super. Great, thanks everybody. If you've missed a question, don't worry, you can find them on the right-hand side of your screen. If you need a little second to answer, that's also okay. I'll give you time. Okay, super. Thanks everybody. And then 3 really quick questions just on your confidence levels. So how confident are you in applying clinical evidence, guidelines, and patient-specific factors to select and personalize first-line BRAF targeted therapy for patients with BRAF V600E mutant metastatic colorectal and non-small cell lung cancer? From 1, not very confident at all, right up to 5, very confident. And then the next confidence question is this. How confident are you in implementing proactive strategies to monitor and manage adverse events associated with BRAF targeted regimens to maintain treatment continuity and optimize patient outcomes? 1, not confident at all, right up to 5, very confident. If you can share your thoughts, that would be great. Okay, super. And then the final poll question, and then we're going to dive into some amazing education. And the final poll question is this. How confident are you in demonstrating the ability to identify, order, and interpret appropriate biomarker tests to inform first-line treatment decisions in metastatic colorectal and non-small cell lung cancer? If you can share your thoughts, that would be super. Thanks, everybody. If you've missed a poll, don't worry. You can find them all on the right-hand side of your screen. You can scroll up and answer each of them in turn, even as we're beginning. And we really appreciate it. It makes such a difference for us and hopefully helps you with your education as well. Okay, thank you so much. We are going to dive into our education today, and I'm really honored to introduce our speaker for today, and that is Professor Zev Wainberg. And Professor Wainberg is Professor of Medicine at the David Geffen School of Medicine at UCLA. He's also the co-director of the UCLA Gastrointestinal Oncology Program and director of the Early Phase Clinical Research Program at the UCLA Johnson Comprehensive Cancer Center. And he is going to be delivering a session covering each of our learning objectives today. Dr. Wainberg.
My name is Dr. Zev Wainberg. I'm a professor of medicine at UCLA, and I'm delighted to present Advances in Lung and GI Oncology, Community Oncology 2025, with a focus on BRAF-targeted therapies. Here are my relevant disclosures. The learning objectives of the program are to apply clinical guidelines and patient-specific factors to select and personalized therapy for BRAF targeted therapy for BRAF V600E mutant metastatic colorectal cancer and non-small cell lung cancer, to implement proactive strategies to monitor adverse events associated with these therapies, and to demonstrate the ability to order and interpret appropriate biomarker tests. So we'll begin with a case. This is a 68-year-old male who presented with fatigue and a change in bowel habits. A colonoscopy revealed a large mass in the right colon, the ascending colon. The biopsy confirmed adenocarcinoma. The CAT scans unfortunately showed multiple liver metastatic disease, and the tumor was deemed unresectable. On the genomic profile of the tumor, there was a BRAF V600E mutation detected with no mutation seen in KRAS, and the microsatellite status was stable, so no mismatch repair deficiency. He had a good performance status with an ECOG of 1. The discussion questions center on considering his molecular profile and performance status. What are his treatment options? What is the evidence for using a triplet combination of chemo plus targeted therapy in this context? And how do the efficacy and safety outcomes of this regimen compare to the current standard of care? So we'll walk through a BRAF mutated colon cancer, which represents about 8%. It seems to represent a little higher in earlier stages of disease, but in advanced disease, in those with stage 4 metastatic colon cancer, we're probably talking about 8%. You can see here how we are increasingly able to divide the pie of metastatic colon cancer, as we'll talk about in lung cancer as well, into subgroups with about half having a RAS mutation, and then a whole bunch of other smaller ones. MSI high represents about 2 to 3%, but BRAF V600E represents a decent number of patients, 8% annually. The clinical relevance of this is quite unique. As we all know, the context of how it presents is similar to the patient's case, more likely to be in the right side of the colon, more likely to present with a large mass, often is poorly differentiated histology, and has sometimes mucinous cells. About 15 to 20% of the time, they also have a deficiency in mismatch repair. There are different classes of BRAF mutation. The main class, the one we'll be discussing, represents V600E, and there are other classes with non-V600E mutations where the targeted therapies are not effective, it seems. Now, we first recognized that BRAF mutated colon cancer had a poorer prognosis than the other groups, in which the progression-free survival and overall survival were lower than the other subtypes of colon cancer. So there's a few important things to keep in mind. When should we test? How should we test? And why? The when is now standard. It should be tested at the diagnosis of metastatic disease. So the first onset of advanced disease, we should be doing a test. And you can do PCR, which is the basic, or you could do next generation sequencing, which of course has become a much more common tool because it captures mutations beyond V600E. The why is that we can now incorporate therapy into the plan. So it's critical to know in advance, ideally, of first-line metastatic disease, whether the patient has a BRAF V600E mutation. There is pretty good evidence that most of the time you can pick this up by liquid biopsy. There have been a few studies done, I highlighted one here, in which the correlation between tissue and liquid was reasonably high. It's not perfect, of course, but there is concordance, upwards of 90%, that can be identified on a liquid-based biopsy. So if, for example, there is no tissue specimen with which to determine the BRAF mutation status, one can certainly do it on a liquid biopsy. Now, in the beginning, there were some studies that looked at what is the role of chemotherapy. And one of the first clues was that there was this TRIBE study which used a triplet chemotherapy regimen, FOLFOXIRI plus BEV. It was a study that compared FOLFIRI-BEV to FOLFOXIRI-BEV, but in the group of patients who have BRAF mutation, they showed a very large benefit in the group of patients who had FOLFOXIRI. So that led some people to use that regimen more likely in front line, knowing that they had a poor prognosis. This is before, of course, the advent of targeted therapy. Ultimately, in a meta-analysis, it really wasn't clear whether this mattered at the end of the day. And of course, the advent of targeted therapy has changed the paradigm significantly. The other thing to keep in mind is that most of the time, as I mentioned, but not exclusively, BRAF V600Es fall on the right side of the colon, which we already know is a poor prognostic subgroup. So thinking about your patient, you have a right-sided, big, bulky tumor, that's the time you should start thinking about a BRAF V600E mutation. Now, the first trial to really look at this in front line was called the Breakwater trial. And the Breakwater trial combined encorafenib and cetuximab, and we'll talk about those two drugs individually. Encorafenib is a BRAF inhibitor directly blocking BRAF V600E, and cetuximab, of course, is an EGFR inhibitor. And there was a safety lead-in that was about 30 patients that combined this with FOLFIRI and with FOLFOX in 2 separate cohorts each, and showed reasonable tolerability profile and encouraging early activity. So they launched what was called the randomized phase 3 Breakwater trial, which you can see the schema of here. Arm A had no chemotherapy, just encorafenib and cetuximab, so chemo-free. Arm B had encorafenib, cetuximab, and FOLFOX. And Arm C was the control arm. And the control arm could be any chemotherapy with or without bevacizumab. Now, we should know that the reason Arm A was done without chemo is because there had already been at that point a approval of that regimen in second-line colon cancer. The safety lead-in I'll show here very quickly. Look, very nice waterfall plots, encouraging responses in the safety cohort. You saw, regardless of whether it was FOLFOX or FOLFIRI, encouraging safety and efficacy in that the median PFS far exceeded what we might have expected. Now, this came based on some science. As I mentioned, why combine with chemotherapy? Well, the reason to combine with chemotherapy is that we know that drugs have synergy. And synergy doesn't just mean between individual agents, it also means in combinations with chemotherapy. And this was a nice preclinical paper that commented a little bit on the value of combining with chemotherapy regimens. So that, in fact, if you combine with chemotherapy up front, rather than waiting until the tumor has some degree of progression, a better outcome might be foreseen. So here again was the study schema. It had 637 patients. It was in patients with no prior therapy, again, randomizing originally to one of 3 arms, encorafenib plus cetuximab in the top arm, encorafenib, cetuximab, and FOLFOX in arm B, and the standard of care. Now, you'll notice that the numbers are a little different because in the first arm, encorafenib plus cetuximab alone, that arm was closed. And the reason it was closed is that at that point, like I said, there was some interest in looking at that arm, but it was quickly deemed inferior to the chemotherapy combination arm. So at that point, the study changed to be a randomization to only the bottom 2 arms. The co-primary endpoint was overall response rate and progression-free survival, with secondary endpoints including overall survival. So first, the overall response rate. You can see on the left, the overall response rate by blinded independent central review was 66% with a combination of FOLFOX, encorafenib, and cetuximab, and only 37% with chemotherapy, so significantly improved. Interestingly, with encorafenib and cetuximab, the response rate was 45%. So some responses were indeed seen. When you looked at median progression-free survival, you could see that the study met its primary endpoint. There was improvement from the standard of care arm, which was chemotherapy alone, of 7 months to 12.8 months median progression-free survival in the investigational arm. This was, of course, statistically significant and met its co-primary endpoints of both response rate and progression-free survival. They also looked at interim overall survival at that point. And here, too, the hazard ratio is 0.49, with a median overall survival of 30 months in the investigational arm compared to 15 months in the control chemotherapy arm. So, again, this was something quite impressive, doubling the overall survival in the group of patients who got FOLFOX, encorafenib, and cetuximab compared to chemotherapy alone. This led ultimately to an FDA approval. When we go over a toxicity profile, what was noticed is that when compared to the chemotherapy arm, which was often FOLFOX alone, but not exclusively, sometimes FOLFOX-Bev, there was a different pattern in the recognition. Mostly, there were increases of anemia, which were more pronounced in the encorafenib cetuximab plus FOLFOX, neutropenia, slightly more, and a little more rash that was noticeable, of course. Now, keep in mind that a lot of the patients in the control arm did not get cetuximab, but there wasn't much grade 3 rash. It was mostly grade 1 and 2. So overall, the safety profile of this combination was actually quite tolerable. Now we'll go back in time a little earlier and talk about what led to this. And this is going back almost 10 years. First showing that single agent BRAF inhibitors had very, very low activity. That was vemurafenib, and even dabrafenib and trametinib had low activity. But as we started to get to more modern therapies, we started to see good activity, culminating in the BEACON trial, which we'll talk about, encorafenib, cetuximab, and binimetinib. Now, this was a second-line study. This was a study in patients who already progressed on frontline chemo. They did a safety lead-in of this combination, encorafenib, cetuximab, and binimetinib. Now, binimetinib is a MEK inhibitor, so it's downstream of BRAF. And in this study, the control arm was also chemotherapy with or without cetuximab, with the main investigational arm being encorafenib and cetuximab. There was also a third arm, as I mentioned, binimetinib, encorafenib, and cetuximab. You could see that the primary endpoint of the study, which was survival, was met in the encorafenib cetuximab arm over the control arm with a hazard ratio of 0.61. That the combination of the BRAF plus EGFR in second line was superior to the standard chemotherapy at that time, both when it came to overall survival and progression-free survival. The adverse events on the BEACON trial were very similar to what we just talked about with the Breakwater study. On the BEACON study, there was obviously a little more rash, and some degree of cytopenias as well were a little more common than in the control arm. Quality of life study was done. A maintenance quality of life using an EORTC scale was done on that study and showed that indeed there was improvement in the quality of life scale in the group of patients who got the combination of those two drugs over chemotherapy. So that led to the approval in second line of encorafenib and cetuximab. And as you can see here, the guidelines were immediately changed, both from ESMO and from ASCO and from NCCN. So what do? We also know that we now have frontline approval and second-line approval, but it wouldn't make sense to use the drug in second line if it was already received in frontline. So the standard of care remains frontline FOLFOX, encorafenib, cetuximab. If they didn't receive encorafenib, cetuximab in second line and they're BRAF mutant, I would do it then, possibly without chemotherapy. That would depend on the individual characteristics. Now, one of the interesting things to come out of these studies is you can try to understand a little more about the biomarkers, try to understand a little bit more about optimizing patient selection, even beyond BRAF V600E. And as I mentioned, there's about 15 to 20% of patients who also have microsatellite instability. And again, there were no immunotherapy used in this agent. So one of the interesting biomarkers studies was looking at characteristics such as MSI high and something called RINF43, which is a possible isolated biomarker that was looked at in this nice study. There was a trial that was launched, interestingly, with encorafenib and binimetinib and cetuximab in front line. This is called the ANCHOR trial. You can see it here. It was ultimately abandoned, as I mentioned. But what was more interesting was a recent study called encorafenib, cetuximab, and nivolumab, which was the combination of the BRAF, EGFR, and, of course, the checkpoint inhibitor nivo in BRAF V600E mutation. And you can see here, small study, but in 22 evaluable patients, the response rate was over 50%. This is in refractory disease, so not first line. This is second line and third line. And this was somewhat encouraging, have an overall survival of 15 months. There was a similar study done with a different common backbone, dabrafenib and trametinib, which is also we'll talk about that a little later, a BRAF and a MEK inhibitor, and another anti-PD-1 antibody, also showing a nice response rate. So the question is, do we need the checkpoint inhibitor? Should we add it to the group of patients who are BRAF V600E who have co-occurring mutations? You can sort of look through in the pivotal, this is the pivotal checkpoint inhibitor study in metastatic colon cancer. This was in the study of Keynote 177. And when you looked at BRAF mutated patients, there was certainly small numbers, but there was the suggestion of benefits to a checkpoint inhibitor. But how do we sequence these things? Should we start with a checkpoint inhibitor, then go to encorafenib, cetuximab, and then only do chemotherapy later? I think that's how most people would consider the scenario. Start with a checkpoint inhibitor and use encorafenib and cetuximab in second line. The question is being addressed right now in a randomized study called the CMARC study. Patients are randomized to either pembrolizumab, which was the standard of care. Now many people use ipi/nivo in newly diagnosed MSI-high, or pembrolizumab plus encorafenib and cetuximab. The primary endpoint is progression-free survival in those patients that have co-occurrence of MSI-high and BRAF V600E. We'll wait for the results. So overall, when it comes to BRAF V600E mutated colon cancer, we're talking about a diagnosis that's present in 8 to 12% of cases. The first-line chemotherapy plus Bev was very ineffective for those patients. So now we have a full FDA approval. This slide actually should be changed from accelerated to full FDA approval for patients based on the Breakwater study with the combination of FOLFOX and encorafenib and cetuximab. We also have a secondary approval for metastatic colon cancer after progression on chemotherapy, if they haven't received it already, of encorafenib and cetuximab alone. Now, moving on to non-small cell lung cancer. Non-small cell lung cancer also has a very common pie chart. I didn't even put in the PD-1 expression. That is one of the most important biomarkers in that disease, certainly. That's all intermixed here, of course. But you can see here a smaller group. It's probably 2 to 3% of metastatic non-small cell lung cancer has BRAF mutations. Those mutations are not even, about half of them are V600E. So only about 2% are V600E. The other are those non-V600E mutations. The first trial to look at this was in a refractory group of patients where they combined dabrafenib and trametinib. And again, dabrafenib is a BRAF inhibitor. Trametinib is a MEK inhibitor. So you're blocking successive parts of the pathway. The EGFR inhibitors, cetuximab, less important in lung cancer and colon cancer, of course. So these weren't tested initially. But the combination was tested, and actually a number of years ago, in 36 untreated patients. And ultimately, 36 patients were evaluable. Here you can see a very nice waterfall plot with about a 40 to 50% response rate. You can see that the very large majority of patients had a response. Many of them were sustainable with median PFSs, which were encouraging. And this was the first trial to look at the combination of BRAF plus MEK. More recently, the encorafenib plus binimetinib trial was done. Again, encorafenib plus binimetinib, same thing. BRAF plus MEK, no EGFR. And this is the overall study design. You can see on the bottom, this enrolled patients who had BRAF V600E mutant non-small cell lung cancer with no secondary mutations, no EGFR, no ALK, no ROS1, no more than one prior line. Patients were treated who were treatment naive and previously treated. So 2 different cohorts were actually enrolled with the combination of encorafenib 450 once a day and binimetinib 45 milligrams BID. The primary endpoint was the overall response rate. Here are the two cohorts of patients you can sort of see in this table. On the left, there were 59 patients who were treatment naive. On the right, 39 patients who were previously treated. You could sort of get a feel for whether they had received immunotherapy or not. And obviously in the treatment naive, none had. But in the previously treated, about 60% had received checkpoint inhibitors at some point, and about half haven't received chemotherapy. The overall response rate, which you can be seen on the right, using the latest data cutoff, was 75% in the group of patients who are treatment naive. So a very high response rate. The things we're used to in non-small cell lung cancer with activating mutations. 75% response in treatment naive patients, with 46% response in the group of patients who had previously treatment. Keeping in mind that the majority of these was partial responses, but a number of CRs were seen as well, quite remarkably. And the median duration of response is quite impressive. In the treatment-naive patients, it was 40 months, so quite a few years, obviously. And in the previously treated patients, 16.7 months. So these were quite encouraging. Here you could see the median PFS in this study on the treatment-naive cohort on the left was 30 months. So that's progression-free survival. And in previously treated, 9.3 months. So obviously, quite a bit more effective if these drugs are used up front, validating, of course, what we've known for many years, the importance of full mutational testing in non-small cell lung cancer. The overall survival median wasn't reached as of the last data cut in the 59 group of patients. In the previously treated group of patients, it was 22.7 months. Needless to say, we expect a very long median overall survival in the cohort on the left with the combination of dabrafenib and binimetinib. The tolerability profile was consistent with what we knew from these drugs. You do get some rash, obviously, and you do get some nausea. Most of the grade 3, 4 toxicities were GI and cytopenias, although rash in some patients was seen up to 8%, and nausea. So in conclusion, about 2 to 4% of patients with non-small cell lung cancer have the BRAF mutation. In previously treated patients, the median overall survival in that subgroup was 22.7 months. The safety profile in both studies is consistent with individual components. Now we have 2 FDA-approved regimens, dabrafenib and trametinib, based on the first data set, which was approved in 2017, and more recently, encorafenib binimetinib in 2023, showing those impressive results. The take-home message of BRAF in general is, number one, we should be testing every patient with colon cancer and non-small cell lung cancer for this mutation. This can be done in a number of ways, as we discussed, tissue-based or even liquid-based if there's no tissue specimen available. From a colon cancer perspective, this represents a poor prognostic subgroup that deserves adequate and specific treatment, and the standard of care is now FOLFOX plus encorafenib plus cetuximab based on the Breakwater study. If that was not received and the patient progressed on chemotherapy alone or some other combination, you can also use encorafenib and cetuximab in second-line metastatic colon cancer based on the Beacon trial. These 2 regimens have now been incorporated in worldwide guidelines of the management of BRAF V600E metastatic colon cancer. We await the results of a new trial to determine whether checkpoint inhibitors should be combined in the group of patients who have both MSI-high and BRAF V600E. Non-small cell lung cancer, BRAF V600 represents about 2% of patients. They have 2 treatment options, including dabrafenib and trametinib, or more recently, showing the remarkable results in the Pharos trial of encorafenib and binimetinib. I'd like to thank you for your attention today and happy to take any questions. Thank you very much.
Thank you, Dr. Wainberg, for an incredible piece of education. We're going to pull up the QR code so that if you want to claim CME for attending today, that will be shared on your screen just now. Just scan that QR code, leave us a quick bit of feedback, and you'll be able to claim your free CME certificate for attending. And we'll also place the link for that into the chat as well. Thank you so much, Dr. Wainberg, for that incredible presentation. We've got some questions here, and I'd love to work through as many as we possibly can. We've got quite a lot, but thank you so much for joining us for questions and answers. For BRAF V600E mutant metastatic colorectal cancer, how do you weigh the trade-offs of using a combination regimen like encorafenib cetuximab chemotherapy versus an intensive chemotherapy biologic regimen when selecting first-line therapy for an asymptomatic patient with good performance status?
Yeah, it's a good question. First of all, thanks for the opportunity to be here and talk about this interesting topic. I think prior to the release of the breakwater data, many people were not convinced that using it up front would be a meaningful difference relative to chemotherapy alone or chemotherapy plus bevacizumab. But if you look at the breakwater study, that's exactly what was randomized. The exact patient population that was randomized was FOLFOX bev or FOLFOX, investigator's choice chemotherapy. It could have been FOLFOXIRI, in fact. And indeed, the survival improvement was there when you added encorafenib cetuximab to FOLFOX. So even if you looked at the subset of patients with FOLFOXIRI bev in that subset, there was still the suggestion of benefit with encorafenib cetuximab, implying that blocking the oncogene upfront is actually a critical point, not waiting till second line. So now that the breakwater data has been released, I personally feel that FOLFOX encorafenib cetuximab should be the gold standard, even ahead of FOLFOXIRI-based chemotherapy. I think it's very reasonable to use FOLFIRI in second line in that patient population now, but there is some value, it seems clear, in complete oncogene blockade of the BRAF mutant oncogene from the first point of diagnosis and not waiting till the disease has progressed.
Next question is this. Given the heterogeneity of BRAF V600E metastatic colorectal cancer, are there specific patient or tumor-related factors that influence your choice between a doublet or a triplet regimen in the upfront setting?
So I think now that the breakwater data is clear that there's a survival advantage, there's a response rate advantage, a PFS advantage, I see no reason not to give a triplet therapy in the large majority of patients. In the large majority of patients who have symptomatic disease, which often BRAF is, FOLFOX and encorafenib cetuximab seems to be the right decision for that group of patients. Where you could, of course, have circumstances where it's not appropriate is an absolute contraindication, someone with some congestive heart failure, someone with a pre-existing reason why you can't use oxaliplatin, for example, then it calls into question that base chemotherapy. But I think on the average patient, that's the appropriate thing to do right now.
In a newly diagnosed patient with BRAF V600E mutant metastatic non-small cell lung cancer, what is your practical approach to choosing between the two FDA-approved BRAF MEK inhibitor combinations?
So, I mean, practically speaking, there's no head-to-head data. So it ends up being extrapolation of both the two existing data sets side by side, durability of the regimen, and perhaps that's where the Pharos regimen has some advantages in that we've now seen 1, 2, 3-year follow-ups, so long-term follow-ups of those studies, suggesting indeed there's a very compelling overall survival median observations in that group of newly diagnosed patients. So at the end of the day, when you don't have head-to-head data, you end up extrapolating, comparing two independent standalone data sets. I don't think we'll ever have head-to-head data. Well, I shouldn't say never, but it won't be easy to do in this very rare subset. So I think at the end of the day, when you look at those two side by side, the encorafenib binimetinib regimen seems to hold up. So that would be my preferred regimen.
If a patient with BRAF V600E metastatic colon cancer who has a good response to first-line targeted therapy is approaching an extended period of treatment, what are your principles for dose modification or de-escalation of the cytotoxic chemotherapy component to optimize the long-term benefit to risk profile?
Yes, that's a good question. And I think the FOLFOX regimen, we all know oxaliplatin can only be continued for a certain period of time. In the Breakwater study, there were guideline modifications to how to discontinue oxaliplatin as per the standard approaches, which is usually 4 to 6 months into it, and then to continue the balance of the regimen. And in this case, the balance would be 5-FU and encorafenib cetuximab for a period. In most patients, I think we have the ability to even drop 5-FU out of the equation, provided the patients are doing well, and try to continue on with encorafenib cetuximab alone for a period. And in fact, that was done in a decent chunk, and I don't remember the exact percentage of patients in the Breakwater study. So that would be my approach. Discontinue first oxaliplatin, then a few months later 5-FU, and then try to continue along with encorafenib cetuximab for as long as possible.
With the evolving treatment landscape, what is your preferred reflex testing strategy, tissue-based NGS or liquid biopsy, to ensure all critical first-line biomarkers are available promptly for a new metastatic colon cancer diagnosis? And how do you manage discordant results between tissue and plasma?
It's a good question and a topical one. So discordant results, we'll start with that. They do occur, and I think tissue still trumps plasma in terms of being an optimal, an optimal way to assess biomarker eligibility. So I think, for example, if I have a tissue that says a mutation and a plasma that says no mutation, I trust the tissue. That's number one. Number two, I think that the optimal way to do this now, it's clear, is from the get-go. So as soon as you make a diagnosis of advanced disease in the context of colon cancer, sending out a quick tissue is the way to go. If there's no tissue available, for example, if the patient got diagnosed in another state or another country, and now you want to know quickly, I think liquid biopsy has a very valuable role in that context. But if the patient is a local patient and you can send it out quickly to any number of vendors who now have a CLIA certified next generation sequencing platforms, I think getting it turned around pretty quickly is the critical element.
Interesting question. For patients with metastatic colon cancer, current guidelines recommend avoiding EGFR inhibitors in the presence of a RAS mutation. In the context of the BRAF V600E mutation, why is the dual blockade of BRAF and EGFR necessary to achieve clinical benefit?
Good question. And it's based on a lot of elegant preclinical data that's been the subject of about 15 years of study, indicating that patients who have BRAF mutations have what's called resistance mechanisms through the EGFR pathway, which means that if you just block BRAF alone, which was done about 15, 20 years ago, and in some of the same people like Scott Kopetz and all these other people have been doing this research for many years, showed that if you block BRAF alone, you immediately have resistance within a short period of time because the cancer now goes through the EGFR pathway. So in order to limit that, we now block both BRAF and EGFR, such that, for example, making it very distinct from, let's say, single agent BRAF blockade alone. And that seems to be unique to the BRAF pathway, although there is some suggestion that with these KRAS inhibitors, that may also be relevant as well. But scientifically, we know that blockade of both BRAF and the escape mechanisms of EGFR are critical, and we shouldn't be using BRAF inhibitors by themselves.
What are the most common, frequent, or concerning grade 3-4 adverse events seen with the combination of encorafenib cetuximab chemotherapy in the first-line metastatic setting, and what specific proactive interventions do you use to mitigate these toxicities to maintain dose intensity?
So if you look at the tolerability and toxicity profile of the Breakwater regimen and encorafenib cetuximab FOLFOX compared to FOLFOX alone, it's actually not too imbalanced. There is a reasonable set of toxicities that are due to chemotherapy, which include nausea and anemia and thrombocytopenia. You do have a little greater grade 3-4 anemia when you combine encorafenib, cetuximab, and FOLFOX, which means keeping a closer eye on blood counts, of course, is topical. And you also have, to some extent, a little greater rash. Most of the rash, though, was not grade 3-4. Most of the rashes were grade 1-2, implying that, number one, prophylactic management of this is a good idea, with the doxycycline is indicated, and steroid creams, in which making the rash, or acknowledging that the rash will be there in a grade 1-2 level, but keeping it from getting to a grade 3-4 level, which is a very practical way to manage some of the most common toxicities.
In clinical practice, what is the most challenging adverse event associated with BRAF-MEK inhibitor combinations in BRAF V600E metastatic non-small cell lung cancer, and what are your management strategies to avoid treatment discontinuation?
So I think the nausea is still an issue. So nausea is one of the more common toxicities that was seen in the Barrow study and in the dabrafenib trametinib study, acknowledging that indeed there's a whole bunch of other GI side effects, nausea, vomiting, even fatigue, the typical stuff. So prophylactic management with antiemetics, supportive care stuff is critical. There was also some laboratory values, so you have to keep an eye on labs. There were no major unexpected toxicities with those regimens, which is why I think that most of us by now are quite familiar with this. So I think it's we're pretty good at managing these things prophylactically.
What is your opinion on the emerging strategy of combining a BRAF-targeted regimen with immune checkpoint blockade in the first-line setting for MSI-high BRAF V600E metastatic colorectal cancer, and how might this change the current sequencing paradigm?
Yeah, it's a good question. Pretty timely. MSI-high colon cancer, that is, we know that these people should get checkpoint inhibitors from the beginning. Some people use pembrolizumab alone. Some people use dual checkpoint inhibitors at Nivo. I think that we don't have a lot of evidence. We have small phase 2 studies showing pretty high response rates, but there is a randomized study that's ongoing called the CMARC study, which is randomizing patients with MSI-high BRAF mutant colon cancer to either pembrolizumab alone or pembrolizumab plus encorafenib and cetuximab. So looking at sort of this exact question, I think for now, because we don't know the answer to that question, often what people are doing is first the checkpoint inhibitors and then the BRAF targeting agents in second line. Although I will say, there's no right or wrong answer to that specific question.
And final question that I think we can squeeze in a patient with BRAF V600E metastatic colon cancer who progressed on a chemotherapy-free doublet regimen in the second line, what are your considerations for third line options, particularly regarding rechallenging with chemotherapy or the role of other targeted agents?
Yeah, so we don't yet have data on what to do beyond BRAF inhibitors, specifically with BRAF second generation BRAF inhibitors, for example. There's no evidence that we should be re-challenging with the BRAF inhibitor after they progress on one. So regardless of whether to get in first line or second line, there's no data we should be using that again in third line. So I think what we do in third line in practice is use chemotherapy. The chemotherapy certainly can be something that wasn't received in front line. So for example, if they got FOLFOX, you can use irinotecan-based therapy, or if they didn't receive TAS-102 bevacizumab, that would be the standard third line, one of the standard chemotherapy regimens. Of course, if they're MSI high, you want to use a checkpoint in third line if it hasn't been utilized already. But in the typical scenario, which is someone, let's say, got upfront chemotherapy, bevacizumab, followed by, let's say, encorafenib cetuximab because they didn't know their BRAF status, now they're in third line, I would consider in that patient irinotecan-based treatment.
Dr. Wainberg, thank you so much for joining us and for taking so many questions. We really appreciate your time and an amazing piece of education.
Pleasure to be here, Phil, and thank you very much. I appreciate it.
And to those of you in our audience, we're just going to pull up the QR code on the screen again for you to claim your CME certificate, and just give that a quick scan, give us some feedback. We'll place the link in the chat for you as well, and we really appreciate you giving us a little bit of feedback and claiming that CME certificate. Thank you so much for joining us, Dr. Wainberg. For those of you who have joined MEDAL events before, you'll know that we like to have a conversation with a patient, and I've had the opportunity to talk to Laura, and Laura is a patient who has experienced lung cancer, and she's shared a little bit of her perspective on some of the topics that we've been learning about this evening. I hope you'll stay and listen to the story from Laura whilst you're completing your CME certification. I am really honored to be joined by Laura today, and Laura is a patient who has experienced lung cancer, and I'm really grateful to be able to have a conversation with her a little bit about her journey. Laura, thank you so much for joining us. I wondered if you could maybe start by sharing a little of your story from your first symptoms to your lung cancer diagnosis.
Sure. So in 2015, I had just retired from my job, and I was about to move across the country from New York to Washington State. And one morning I cleared mucus in my throat into the sink, and there was a tiny thread of blood in it. And I had no other symptoms, but since I was a hypochondriac at that point, I made an appointment with my primary doctor, and he sent me to an ENT doctor. So the ENT doctor examined me and told me I had an irritated throat and nasal polyps, but he also ordered a chest x-ray just to be safe. And by the time I got back from home from the chest x-ray, I had a call from the hospital asking me to come in for a CAT scan because they saw a nodule in my lung in the x-ray. And I was then told to follow up with a pulmonologist, which I did. He said, we could watch it. And so I scheduled an appointment with a pulmonologist when I arrived in the Seattle area. And he didn't seem to be too concerned. He thought it was could be I think he said an infiltrate or something, or and he said I should continue to get CAT scans every 6 months, but nothing changed. And so around July of 2016, I started to get really severe pain in the back of my neck. I got an appointment with a physiatrist who ordered more tests, and also prednisone because I was in a lot of pain. And then she told me, because I was worried it was cancer, because I was always worried about getting cancer for some reason. She told me it wasn't cancer, but that I should see the orthopedist to make sure if my neck was stable. So when I saw the orthopedist, he said that he believed that the nodule in my lung was cancer and that it had traveled to my C4 bone. I asked him why the physiatrist hadn't told me it was cancer, and he just said that she didn't have the guts to tell me the bad news or something like that, which was kind of strange. And I was really angry. I couldn't believe that he was, that what he was saying, and he had to keep telling me, no, it's, I know it is, and I know it's a shock, but this is the truth, and you have to treat it, and so it was pretty shocking.
Thinking back to that overwhelming diagnostic period, we've been talking a little bit about biomarkers on our education session today. When did you first learn about biomarker or molecular testing, and what was that like? How was that concept explained to you?
So I vaguely recall, I got a thoracic oncologist, and I vaguely recall him saying something about biomarker testing, but to be honest, I was just so godsmacked, is that how you say it? It didn't really register with me. But the biopsy did show that I had a targetable mutation. So I really didn't know very much about it, and I was in no state to absorb that information, to be honest.
And based on your experience, what advice would you give to community oncology teams about how to best explain the purpose and timing of biomarker tests to a patient who's still processing a new diagnosis?
It's a hard one. So when you're diagnosed with lung cancer, you're so overwhelmed and in shock and worried that you're going to die soon. It's really hard to take in much information other than how much time do I have left. I would advise an oncology team to first get a newly diagnosed patient to a support group to talk about their fears about mortality, their concerns, about how it's going to affect their families, and then point them in the direction of a biomarker group, advocacy group. There's BRAF group that concentrates on patients with BRAF mutation. They're, on Facebook, and they're private groups, and they're very active, and people really are very supportive. There's a lot of good information in there. And I think it's really important to connect patients with that particular group, and also organizations, well, in the United States, like Longevity and GoTo Foundation. Again, it's a lot of information coming at them at a time when they're really in a tizzy. And maybe when they have subsequent visits with the oncology team and the dust has settled a little bit more, that would be a good time to check in with them on their understanding of their disease.
And once your test results were in, how did your care team discuss your first treatment plan with you? What did they do or say that gave you confidence in the recommended path?
It's all really vague to me because I was like in an altered state, to be honest. I remember my oncologist setting me up with medication and saying that, I had a special mutation, that there was this targeted medication for it. And I remember reading about the side effects. There was a book that they gave me with information, and it all sounded pretty scary, the side effects. To really be honest, I don't think that they could say anything to give me confidence at that point. I knew I was stage 4 and it was incurable and it was cancer.
What can a clinical team, the doctor, nurse, pharmacist, do to make you feel comfortable calling them about new or worsening side effects rather than just toughing it out at home?
Yeah. In my particular situation, I did develop a nasty rash from the medication, and the medical staff communicated that I should stop the medication for a week and see if the rash was better. The skin on my face looked really bad, and I was very self-conscious and embarrassed to be seen. It did resolve, so I was able to resume medication after 10 days with dose reduction. I think at this point, the best thing that the team can do is make sure that they have someone who is very responsive and reassuring communication with the patient. I think, again, to be honest, I don't think many doctors realize how their staff members treat patients. In my experience, I've felt that they're there to protect the doctor against the patients, so that the patients don't bother him or her. And I think that's really not, I don't know if the doctor's aware of that or if that's what he wants them to do, but it's really important to have staff that are compassionate and don't make someone feel like a pain in the ass, basically, by calling in about their side effects or whatever.
What do you see as the biggest unmet need or communication gap for patients starting a new targeted therapy in the community setting? So
in my opinion, I think the major unmet needs, probably psychological at this point. How do you deal with fear and anxiety? How do you tell your family and kids and friends that, you're maybe terminal or you have cancer? I mean, cancer is one of the most scary things people could imagine happening to them. I think they need to clarify their diagnosis in layman's terms, and instead of using, fancy medical terminology, and let patients know where to find important information for learning about their disease, because I believe that a well-informed patient and who advocates for him or herself is going to live longer and get better care. Access to patient educators like nurse navigators for financial support, palliative care, access to expensive medicine assistance, medicine assistance or discounts. That's important. Many institutions say they work as a team, but they really don't. And patients don't want to be ping-ponged to various doctors when they have either side effects or problems. They don't know whether it's related to cancer or it's related to something else. So I think that's important as well.
And if you could give one piece of advice to all the healthcare professionals in our audience today, what would be the most important message you'd want them to take back to their clinics?
I would suggest that they be very kind to their patient, compassionate. Don't speak to them condescendingly. Listen to your patient instead of just talking at them, and be open-minded and try to use patient-friendly language, not medical jargon. And most importantly, allowing patients, if they choose, to share in decision-making about their treatment. and allow, time for questions and not rush the visit. Also, I would encourage doctors not to be closed-minded about complementary therapies that, are offered by oncology, naturopaths, or other medical experts. I think those are the most important advice I can provide.
Laura, thank you so much for joining us and for sharing your insights. We have these conversations because it brings everything back to why we do it, which is about the patient at the end of the day. So thank you so much.
Thank you.
What a really powerful story from a patient who has experienced lung cancer. And that's why we do this education at the end of the day. I hope that you have found our session today helpful and useful for your practice. We're going to pull that QR code up on the screen again for you to claim your CME certificate. Just give that a scan, give us some feedback. You'll be able to claim your free certificate. It's been a pleasure to host you today, and I hope that we'll see you at another Medal education session sometime soon. Thank you so much for joining us.